Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel, live at the NEI Congress 2019. It's day 2, and we are here with Dr. Sauve for an extended Q&A session. Let's listen in as he addresses your unanswered questions from today's presentation.
So in today's session, I covered brain stimulation, and we had a very large number of questions. So this is going to be a great opportunity to expand on these questions and maybe clarify some concerns. The first question that I see here is TMS FDA approved for children and adolescents? And the simple answer is no. Right? The slightly longer answer is keep your eyes open. This is something that has been worked upon for a couple of years. Last year, the entire field of TMS was extremely enthusiastic that an FDA approval was going to come through sometime soon, all the way down to 12 years old. And there was a little bit of a back to the drawing board kind of situation with the data that came out. So right now the consensus is that it's coming, just not as fast as we had hoped. There are plenty of small studies out there suggesting safety and efficacy in children and adolescents for TMS. So I would say that the consensus is that it's not dangerous to do, and it's probably useful. Because it's still off-label for now, it's difficult to get insurance coverage for that. The next question I see here is, I have a patient stable with long-term medication treatment. They want to get off medication and wondered if they can do TMS now. They would not show any depressive symptoms now, but very reliably would develop severe depression with a reduction of medications. That's a very interesting question that I can't completely answer because it's not my case. Right? So that typically the first question I would ask is, what does stable really mean? And that, not to insult the asker of the question, I'm going to assume that they're quite familiar with their patient. But my first thought, if a patient was telling me that they felt they were stable on long-term medication treatment, is whether are they stable or are they in remission? So what's really going on here? I agree that if a patient is on medication and they're in remission, and it seems as though their continuing medication treatment is maintaining that remission, then you start TMS, and it is very difficult to know what you're doing. If the patient goes from remission to remission. Me personally, as a physician with a heart, I'd feel pretty terrible about taking medications away so that someone could get depressed, and then thinking that I'm going to start TMS and somehow get them back into remission, which might not come true, and now they're depressed. And it's fairly common for people to not get a good result on a second medication trial. You hear that all the time in psychiatry, that someone got well with a particular medication and then they were off it, and then when they had a recurrence of depression, they tried that medication again and it didn't do anything. So that's a pretty artistic question is what I'm trying to say, and I'm pretty sure that is a highly unsatisfying answer. But the answer there is, go slow. I think it would mean a great deal of slow evaluation and really thinking out priorities, and again, whether someone's really in remission and what is meant by stable. So when treating PTSD with TMS, do I recommend using provocation trauma narrative or only use the H1 coil, as it is meant for MDD alone? And if so, how would I do the trauma narrative? Interesting question. Probably my best answer is ask again later. There is some talk that the study to really demonstrate the provocation trauma narrative combined with a TMS treatment is maybe getting spun up now. The pilot study for that has been done. Right now, using a word like recommend, I wouldn't necessarily recommend that anybody try in the office to recreate that pilot study, even though that's something that's been done. And of course, there are clinicians who are going to feel confident enough to do that, and that's wonderful, and find that pilot study, and it can work pretty well. In office, 99.9% of the time when I am treating people who come to me with PTSD that is quite commonly co-occurring with depression, I am using mostly a typical on-label depression protocol, using either an H1 coil or a figure 8 coil, and getting pretty good results with that. And I'm excited to see the work for combining TMS with a provocation trauma narrative, and to somehow get my hands on the correct equipment to do that, and eventually do that. Next question. Please talk about use of TMS for patients who failed ECT. Short answer is that I do that. It doesn't change anything about the protocol. So my take on that is that TMS and ECT don't really have anything to do with each other. And it speaks to one of my pet peeves. I think that in STAR-D, we saw that, one medication trial, second medication trial, people are less likely to respond, and a third medication trial, even less likely, fourth trial, almost nothing. And that is what created this idea of levels of treatment resistance, which sadly, I don't think it was intended this way, but sadly has created an impression that people are sicker and sicker and sicker, that somehow treatments are each one more aggressive than the last, and that you can't go back because somehow the treatment is less aggressive. And I wouldn't say that's true. So even though ECT, as my favorite thing to say is that it's undefeated as the most efficacious treatment for depression in 8 decades, but that doesn't mean that someone who has not benefited from ECT couldn't benefit from something that is seen by many as less aggressive, because again, it's not that it's less aggressive, it's completely different. So it's not uncommon. It's not incredibly common, but it's not uncommon for me to have people come to me who have had 10, 12 medication trials, and they have had ECT in the past, either in the recent past or the distant past, and did not get satisfaction from it. I have done TMS with them, and they have benefited from it. I would say the likelihood is no different than my general population. And I see no reason. There's nothing to change about the protocol. I don't find that having been through ECT creates any particular unique risks. So they come for treatment, we do TMS, and some of them get well, and it's wonderful. Particularly if they didn't benefit from ECT, you have a pretty scared, frustrated patient. So it's really nice, when they get well with TMS. Has TMS been looked at for ADHD? I would say the answer is yes, and so far it's disappointing. It's ADHD, another disorder that is probably highly heterogeneous, and I think the field is having great frustration finding a particular protocol or a particular place to stimulate on the brain that reliably brings about benefit with ADHD. So if you look through the literature, you'll find plenty of small studies, 10 people, 15 people, you get some benefit, and then it never gets replicated. And you just can't seem to find something that works over and over. I've seen some glimpses of some work that was more targeted using tools like quantitative EEG and maybe even fMRI combined with TMS stimulation, so that in the near future someone might be able to identify a subtype of ADHD with a particular biological profile and then stimulate that and see a benefit in ADHD. So a year or 2, 5 years, maybe there might be something useful. For now, not really there. If TMS is stimulating neuron firing, is there a risk of inducing a seizure? And I probably went over this in the presentation a little fast, so that and maybe that did deserve its own bullet. and I'll think about that for future reference. That is the adverse effect of TMS that all TMS practitioners warn people about. So it's number 1 warning on the label. Risk of inducing a seizure, while it is real with TMS, it is typically a 1 out of thousands risk. In a patient who is not already at risk for seizure, it is not an area of great concern. I would say that it's very important to be prepared for having a seizure in the office, no matter how unlikely. At our centers, all of our staff have CPR. and we discuss what they would do with a seizure in the office, which is essentially stop the treatment, call 911, and look after someone's head and their secretions. Seizures that have been documented as a result of TMS have typically lasted no more than a second or two after the stimulation was stopped. So these are not, you really don't hear about status epilepticus or prolonged seizures. So it's a very rare thing. It's very brief. Also really important, there is no risk of seizure except right when the stimulation's happening. So I am able to tell my patients it's perfectly fine to drive after a TMS treatment. There's nothing that they need to worry about walking out of the office. There's no risk for seizure in the car or at home. So seizure is really the greatest concern when risk already exists. And as I alluded to during the presentation, alcohol withdrawal is probably the biggest risk in my mind. Very high dose of bupropion, regular 150 milligram or 300 milligram, some typical doses of bupropion is usually still fine. I warn patients fairly sternly about, seizure risk associated with bupropion on its own. And I warn them not to increase the dose of bupropion while they're going through treatment, because I'd say that's the greatest risk for seizure. If they're at 100 or 450 milligrams a day, that's enough of a risk that we might have a conversation about backing off that dose before doing TMS. So those are things to think about when it comes to seizure. So who is the ideal patient to refer for TMS? I love that question because honestly, I've not found that person. It kind of goes the other way around. I have been practicing TMS for getting close to a decade, and I have been made into a liar so many times when I was not enthusiastic about treating somebody that I stopped that. I have had enough cases, which of course is wonderful, where I really didn't see how something like TMS was going to be successful, and those patients got into remission. And I've now come into an emotional place where I tell people asking me that the best thing to do is start. Because in general, it's almost always a very low risk procedure, and the chance of success is, higher than I ever would have thought, before I actually started doing this on a regular basis. If you look at the label, thinking about an ideal patient to refer for TMS, in 2008, when this was FDA approved, the label for treatment-resistant depression to be treated with TMS was defined as failure to benefit from one drug trial. And actually, the label in 2008, which I did not read all the way to the end because I sleep just fine. So I got the label and I thought I had it and didn't look at the fine print. The label didn't just say one drug trial. It said one drug trial only. So in 2008, 2009, up until 2014, people who had not gotten a good benefit from 2, 3, 4, or 8 or 10 drug trials that I see fairly commonly were off label. It was one drug trial. So if you thought about that ideal patient, that the picture that the label painted, you would be thinking of a young-ish, 22, first episode depression that's been going on for months, not years, and had one appropriate drug trial. Fluoxetine's not a bad idea. About 8 weeks. They didn't really get better from it. Stop that drug, then obviously, if they haven't gotten any benefit, and TMS would be the appropriate next step. So find that patient, uncomplicated, first episode depression, one drug trial, unicorn, in other words. But you find that person, that might be that ideal picture of someone for TMS. And interestingly, I think that would be a likelihood for a very good outcome. I could see that patient not only getting into remission, but staying well for a very long period of time, being so young, being first episode, maybe being completely into remission. But if you're hunting for that patient, you're going to miss the other 90% of patients, because the average person coming to me has had depression for 2 decades, maybe 3, and 8 drug trials is the average out of my entire population. So 10, 12 drug trials is not super uncommon. What is your threshold for using TMS with a seizure history? Well, again, that's a multi-factor decision. when it comes to people that have a seizure history, that is, for me clinically, that is a case-by-case-by-case basis. So one example of that, I've treated a few people that had some seizures in childhood that were never very well explained, and there isn't really a good way to get, a clear picture of exactly what happened. But we are able to document in this hypothetical patient that they haven't had a single seizure or seizure-like episode since they were 6 years old, have never had to be treated, in their adult life with anti-epileptics, and don't seem to have any risk factors now. I've treated, those hypothetical patients without hesitation, and it's been fine, and we haven't had any trouble with it. I have also encountered patients who have a recent seizure history who have been evaluated, and there is not a reason to believe that they suffer from epilepsy. I've treated people who were evaluated by a neurologist and went through the whole picture, and we're able to make a case that whatever was going on with seizures before, that it doesn't seem to be a big risk factor now. Up to and including people who do have a seizure disorder, and if that seizure disorder is well controlled, and a very long conversation about risks and benefits, and the person who wants TMS treatment really understands what we're looking at, then I can see a possibility where I might treat that person. That said, if that person is hoping that insurance will cover their treatment, that almost always that's going to be a pretty clear contraindication. So a documented seizure disorder, even if it's well treated, well controlled, that's kind of at the top of the list in contraindications for most insurance, and they won't touch it. So then that turns into a whole different logistical animal. So I would say, best answer is case by case by case by case with, the best clinical evaluation you can do. And, it's always going to be risk versus benefit. Does patient have to stop anti-seizure meds for TMS? Following on that last question, again, excellent question, number one. I would say short answer is no. And I would elaborate, first of all, almost never would I suggest somebody stop anti-seizure meds for TMS, no matter why they're taking them. If it was an anti-seizure medication that was meant to be part of a mood stabilization regimen, I very commonly, people come to me who are on lamotrigine that was often, I believe it was put on their regimen as part of an augmentation for depression, not even, not necessarily even meant to be a treatment for bipolar disorder. But in any case, almost never would I be in a situation where I think it's a safety consideration and the medication has to be stopped for the sake of TMS. So this goes back more to, I prefer medications be left alone for the most part during TMS treatment so that we're avoiding random factors and we're only, changing one thing at a time. To put one more brick on that, some seizure medications have rebound associated with them, and stopping them for TMS would probably be a pretty bad day. I think it's possible that you might at least transiently very badly increase that risk of seizure and really wish you hadn't done that. So I'd say they don't have to be stopped, and most of the times I'd be stamping my little feet and demanding that they not be stopped, and sometimes even reminding my patients that this is not the time to skip your meds every once in a while, because we might run into some trouble with seizure risk in TMS if we skip a dose here and there.
Thanks for listening. Stay tuned for the next extended Q&A sessions from NEI Congress 2019, and make sure to subscribe.